Hi, this is Jim Moeller bringing you another sports medicine lecture. Again, I'm the director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. Today we're going to start a two-part lecture series on hip conditions. This series deals with hip conditions in the young adult and adult, as we talked about pediatric hip issues in the pediatric lecture series. Here are some of the goals that we want to accomplish through the course of the next two lectures. And I want to make a general statement about looking at medical literature. Most doctors use medical literature like a drunk uses a lamppost, more for support than illumination. My hope is that we use some of these studies for illumination. Here's a roadmap of what we're going to talk about: muscle strains, hip contusions, trochanteric bursitis, labrum tears, femoroacetabular impingement, and arthritis. So let's get started with muscle strain. The hip region is a very busy place. You have muscles crossing from the trunk down into the lower extremities, muscles crossing from the lower extremities up into the trunk, the iliacus, the psoas, the rectus femoris, sartorius, tensor fasciae lata, and the medial compartment all play a role in hip flexion. The adductors, including the magnus, longus, brevis, and minimus, the gracilis, and the pectineus, are all present as well. And so there's a lot going on. One of the most common injuries that we see is hip flexor and adductor strain, incredibly common problem in athletics. A 2017 report in the American Journal of Sports Medicine looked at 25 varsity NCAA sports across a number of schools and then extrapolated this into the data that you see here. Between the 2009-2010 academic year through 2014-15, there were 770 hip flexor strains seen, and this extrapolated to 28,650 injuries over that time period throughout the NCAA. 621 hip adductor strains were seen, which extrapolated to 24,000 injuries. So again, a very, very common problem. Injuries were more common in males than in females, and more common in games than in practice, which we often see. Men's soccer, hockey, and women's soccer and hockey were the sports with the highest rates. In sex-comparable sports, there was a statistical difference in hip adductor, but not hip flexor strain rate. An approximately 10% recurrence rate was noted, and up to 30% recurrence rate in women's hockey. A study published just last year in the Journal of Athletic Training looked at over 1,600 hip injuries in NCAA football players. Injuries took place at a rate of 5.18 per 10,000 athlete exposures, and 75% of the injuries took place in practice, with over half coming in the preseason time. 75% of the injuries were muscle strains, and 18% were contusions. The average time loss from injury was 5.93 days. The majority of these injuries resulted in time loss of less than 2 weeks, with almost 2/3 being less than a week. Almost all of these injuries were new. Only 9% or so were recurrent injuries, and only 1.1% required operative management. Here you can see the breakdown of the positions that were noted in this study. And again, this is NCAA football players. The history is usually that of acute onset of pain during an acute eccentric load mechanism, such as the hip flexor straining during the sprinting activity in the trail leg, or the kicking activity with the timing of ball strike. Skating can also cause this trouble, especially in the adductor region. It can be from an accumulation of microtraumas as well, however, so a single acute event may not be recalled. Pain is often localized and is present with activities. On physical exam, it looks normal in that region. Neurovascular status is intact, but they usually will have tenderness to palpation over the involved muscle. Range of motion may be reduced passively due to muscle tightness, and it may be reduced actively due to pain. Strength testing often reveals decreased strength, and pain on resisted testing. Special tests such as the Faber and Fader test and the Stinchfield test are often positive. I refer to the Stinchfield test as the resisted straight leg raise test, so you may hear me say it both ways during the course of the lecture. Imaging studies should be considered. X-rays are particularly important in adolescent athletes to rule out avulsion fracture, and it can rule out other pathologies in adults such as osteoarthritis and femoroacetabular impingement. Ultrasound and MRI both potentially play a role if there's consideration of complete avulsion. The treatment involves relative rest, ice and/or heat depending on the timing to the injury, medications such as nonsteroidal anti-inflammatories, acetaminophen, rehabilitative exercises including stretching, strength, and proprioception activities. The treatment of muscle strain injuries and other injuries in sports medicine is often referred to as, you can put in your favorite Mexican restaurant medicine, where you take a similar set of ingredients and put them together in different packages to come up with a treatment plan. And so if you think of a home exercise plan as the meat and ice as the cheese and stretching as the lettuce and so on, you take all these different components and you mix them all together, but you actually come up with different products in the end. Let's talk a little bit about hip contusion. We'll go back to that report in the Journal of Athletic Training. And I mentioned that 18% of the injuries that were noted in that college football group were contusions. That came out to an incidence of 0.94 per 10,000 athlete exposures, with adductor and hip flexor strains being the two more common injuries as we've already discussed. Contusions present as pain in the hip, usually lateral, after direct trauma, typically a single hard contact to the bony prominence or muscle region, but repetitive lighter contacts to the bony prominence or muscle region may also cause a contusion. The athlete will have pain with activities, and particularly pain with direct contact on the area. And that could be significant contact, such as sport contact, direct contact with another player or the ground, but it also could be discomfort simply from lying on the injured side. Visible bruising may or may not be reported. On physical exam, you may see bruising and swelling. Tenderness to palpation is very common, with the iliac crest being the most common location. Some people refer to this injury as a hip pointer injury. Athletes will typically have full range of motion, and the neurovascular status is intact. If the contusion is to a muscle group, they will often have pain on resisted testing of that muscle group. If the injury is to a bony prominence, they may have discomfort as you test the muscle group that attaches to that bony prominence. Because contact is usually the cause of trouble, x-rays are important to rule out fracture. And remote x-rays may be necessary to rule out myositis ossificans. Ultrasound will often show a hypoechoic change with blood collection, and it can be very helpful if there's a hematoma that requires aspiration. An MRI will show the contusion as well, but may not alter the treatment plan significantly. The treatment involves relative rest, ice, medications, rehabilitative exercises, and consideration of padding to the contused area at the time of return to play. Let's move on now and talk about gluteal tendonitis and trochanteric bursitis. Gluteal tendonitis is more common in females than in males. When you look at the 50 to 79 age group, it's present in roughly 25% of females, where it's only present in less than 10% of the males. It's a common problem in runners and may coexist with trochanteric bursitis. Trochanteric bursitis is an irritation or inflammation of the trochanteric bursa, which sits just on the posterior inferior edge of the greater trochanter. It is caused by repetitive irritation from the iliotibial band tracking over the bursa, but could also be from direct trauma. It too is more common in females than in males and is a common running injury. The presentation is usually that of insidious onset pain in the posterior lateral and lateral area of the buttock. Patients point to this area and say it's their hip, when actually the hip joint certainly is more in the what we consider the groin region. This pain may radiate into the buttock or proximal lateral thigh. It is generally worsened with activities and worse with direct pressure, such as lying on the injured side. Sometimes the patient will describe a pop or click with hip motion. On examination, observation is normal, neurovascular status is typically intact, and palpation is tender over the posterior margin of the greater trochanter and or the gluteal musculature. Range of motion is typically normal, and strength may be reduced with resisted abduction, and it could be painful with this as well. I lump these two together because there is a great deal of crossover, and the histories and physical examinations are often very similar. When you're considering gluteal tendonitis and trochanteric bursitis, special tests can also be utilized. Checking the abduction strength has shown that weakness is a good predictor of tendinopathy, but pain is a poor predictor for tear. The Ober test is of limited diagnostic utility. It creates compressive load but not tensile load. Single leg stance is a test that is often used. The patient will actively avoid lateral trunk displacement, and pain at the lateral hip is a positive test. And then, of course, a Faber test can also be utilized. X-rays are usually normal, but it can be helpful to rule out other pathologies, as we've discussed before. Ultrasound sees the bursa well and sees intramuscular calcifications well, but it's less sensitive than MRI at seeing tendon pathology. MRI is very sensitive for tendon pathology. It will show increased signal on T2 images in the bursa, and it's useful at ruling out other pathologies. Generally, I don't use ultrasound or MRI very often in cases of gluteal tendonitis or trochanteric bursitis unless the patient fails to improve with the treatments that are used initially. Treatment includes, as we've discussed before, relative rest, ice and heat, different types of medications. Corticosteroid injection has traditionally been used in this type of injury to assist with pain control. A study published in the British Journal of Sport Medicine in 2018 compared the use of an education with exercise program versus corticosteroid injection in the treatment of gluteal tendinopathy. The control group had no treatment whatsoever. The education exercise group and the corticosteroid injection group did better than the no treatment group, as would be expected. At the 1-year follow-up, the education exercise group did better than the corticosteroid group in terms of global improvement, but no difference in pain intensity. Other possible treatments to consider include shockwave therapy, dry needling, prolotherapy, and percutaneous tenotomy. Let's look at another study that compared home training, local corticosteroid injection, and radial shockwave therapy for greater trochanteric pain syndrome. This was a German study with multinational authors. 229 patients were randomized into either a home exercise program, corticosteroid injection, or shockwave therapy treatment plan. Outcome assessments were performed at 1 month, 4 months, and 15 months. Looking over time, you can see that at baseline their pain scores were roughly the same, certainly no statistical significant difference. There were 70 patients or more in each group. At 1 month after initiation of treatment, the corticosteroid injection group had the greatest pain reduction, and we see this in many studies using corticosteroid injection as a treatment. At the 4-month mark, the shockwave therapy group had the greatest pain relief, and the pain relief from the corticosteroid injection was wearing off. By the 15-month mark, the home exercise program and shockwave therapy group had the greatest pain reduction, much better than what was seen in the corticosteroid group alone. These findings are very similar to findings that other studies have demonstrated in the use of corticosteroid injection for problems such as lateral epicondylitis. Continuing on with this study, when you look at the Likert scale of changes, you can see that the home exercise program had a steady improvement over time, whereas the shockwave therapy had improvement that started to taper off towards 15 months. And when you look at the corticosteroid group, it tapered off quickly and then remained constant. Changing gears again, we're going to move on to the discussion of labrum tear. It was once thought that this was only due to high-velocity trauma, such as what was seen in a motor vehicle accident, but advances in imaging technology has led to a great increase in the diagnosis, and we commonly find this in athletes, particularly hockey players and soccer players. Possible predisposing factors include the presence of impingement, hip trauma, sport participation, hip dysplasia, capsular laxity, and degenerative joint disease. Patients with labrum tears will often present with pain with or without mechanical symptoms such as catching and locking. They also may describe popping or clicking with motion. The pain is usually in the groin region and is often quite vague. Dr. Bird from Nashville described the inverted C sign, where they put their hand on their hip with their thumb directed into the groin region. Onset may be acute or insidious, and the pain is often worsened by activities. On examination, they'll have a normal appearance. They may have a limp. Neurovascular status is intact. Strength is usually intact, but may cause discomfort. And special tests are used, such as the Faber test, Fader test, grind test, Stinchfield test, and log roll test, in order to try to determine the likelihood of labrum tear. The Faber test, flexion, abduction, external rotation test, often does not point to a specific pathology, but anterior hip pain with this test is more likely to represent an intra-articular problem. The Stinchfield test, or the resisted straight leg raise test, may be positive in a hip flexor strain, and posterior pain may be due to lumbosacral issues. So again, it may be difficult to interpret. A click with log rolling may indicate a labrum tear. X-ray assessment is necessary, primarily to assess for other or additional pathologies such as hip dysplasia, impingement, and arthritis. The diagnostic gold standard is an MR arthrogram, which has high sensitivity and specificity. Some physicians will use an intra-articular injection for diagnostic purposes. It's the advent of MRI and MR arthrogram which has led to a significant increase in our ability to diagnose this problem. However, the problem is it may be too sensitive. Here is a study from the Stedman Philippon Research Institute looking at 45 volunteers. These people had no pain, no prior surgery, and no claustrophobia issues. Their average age was 38, but ranged from 18 to 66. There were 28 males in the study and 17 females. Either the right or left hip was tested in each patient, and the patient did not have an option on which hip was tested. The determination of right versus left hip was randomized. Overall, 73% of the hips had some type of pathology. And by consensus of 3 readers, 69% were considered to have labrum tear. In another study, published in 2017 in the British Journal of Sport Medicine, researchers looked at the prevalence of acetabular labrum tears in asymptomatic young athletes. 101 athletes were studied. Most were hockey players, average age of 15 years with a range of 11 to 19. So this is a much younger group than in the previous study. And 70 of these athletes had labrum tears. The incidence of tear was much higher if they were over the age of 16. In fact, if they were greater than or equal to 16 years of age, they were 7 times more likely to have a labrum tear than if they were less than 16 years of age. It was also noted that athletes who had been participating in their sports for 9 or greater years were 5 times more likely to have a labrum tear than if they were participating in their sport for less than 9 years. This confuses the picture. What this tells us is that just because you have a labrum tear present doesn't mean that you have pain and doesn't mean that it's interfering with your sport activities. So once you do a good history and physical examination and you have a high suspicion for labrum tear, there's a very good chance that a well-done MR arthrogram will actually show a labrum tear. We just don't know if that's actually the cause of your pain. Therefore, the next step may be intra-articular corticosteroid injection. This can be used to help determine if the pain is actually coming from the torn labrum that was confirmed by MR arthrogram. Pain relief from the injection indicates that the pain is most likely coming from the intra-articular region. The pain may be short-lived, but if they have good pain relief, then it is more likely that the pain is coming from the labrum tear. If a patient sees no benefit whatsoever, then there's a good opportunity that the pain is coming from something else. Patients who have complete resolution of pain with corticosteroid injection, even if it is short-lived, have an increased likelihood that surgery will be beneficial. Non-operative care is the initial treatment of choice for people with labrum tears. Relative rest, physical therapy, anti-inflammatory medications with or without injections are used. Because there's a high likelihood of labrum pathology on diagnostic testing, even in asymptomatic individuals, and the initial care for labrum tear is non-operative, if I suspect labrum tear in my patients, I go ahead and start with their non-operative care without obtaining advanced imaging. If their pain resolves and they return to their normal activities, then no advanced imaging is ordered, unless, of course, they have return of their pain with return to activities. If they have no response to conservative management, then I already know that they would be a better candidate for surgical intervention if a labrum tear is identified. So I go ahead and get the advanced imaging at that time. In other words, the advanced imaging is not going to change my treatment plan early on. And if it's not going to change my treatment plan, then I don't find it to be a helpful test at that moment. I prefer to obtain my advanced imaging at the time where it is going to change my treatment plans. Again, this is my approach, and this is not the approach of everyone. So in the scenario where you have a supportive history and physical examination, you have failure of non-operative treatment to assist in reducing pain and returning the athlete to their prior sport, and you have confirmation of a labrum tear by advanced imaging, at that point operative care is utilized, with arthroscopic debridement, repair being the primary options. Most athletes do quite well after surgical repair. Many can return to their prior sport, but the long-term outcomes are yet unknown. Let's look at a study that described asymptomatic hip and groin pathology identified by MRI in professional hockey players and the outcomes and playing status at a 4-year follow-up period. This was done out of Penn State University using the Hershey Bear hockey team. 21 athletes were identified as being asymptomatic AHL players on an active roster. Both hips were examined. 15 of the players had a labrum tear, and it was bilateral in 7 of these players. Only 4 players showed no pathology. 90% of the players had remained in pro hockey at the 4-year follow-up. And in the 2 that retired, it was not due to hip or pelvic problems. 3 of the players did develop hip and pelvis symptoms, and all 3 of these players did have labrum tears. Only 1 of these players missed games due to their pain, but it was due to IT band issues. None of the players required repeat imaging or surgery in the 4-year follow-up period. So as I mentioned, my approach is if a labrum tear is suspected based on history exam and x-ray, initiate the appropriate conservative management plan without obtaining advanced imaging. And my rationale is that if the treatment for labrum tear will be conservative if you find it, then it would be reasonable to start conservative management even if you don't know that it's present. And if imaging does not alter the plan, go ahead and start the plan. If the pain resolves, you return the athlete to play, but if it persists, you go ahead and get the advanced imaging, because at that point, your treatment plan will change. If it's positive for labrum tear, then I send them for injection, as I don't do ultrasound-guided hip injections myself, and possible surgery if the injection gives good pain relief. If the advanced imaging is negative for labrum tear, then we need to adjust our treatment plan based on the pathology that is recognized. And again, this is my approach. This is not everyone's approach. So we want to move on to discussion of femoroacetabular impingement, or FAI. The basics are that the ball and socket improperly fit each other, causing pinching in the joint. And I describe to patients that either the ball doesn't fit the socket or the socket doesn't fit the ball, or there could be a combination of the two. And the femur then impinges on the anterior acetabulum. Pain is usually exacerbated in flexion. In cam impingement, the ball is too big for the socket. In pincer impingement, the socket overhangs the ball too much. And the combined type is, well, combined. FAI is often discovered incidentally. An older patient presenting with bursitis, for example, and you obtain a hip x-ray and you see changes consistent with FAI. There is debate as to whether or not we diagnose FAI based on radiographic findings or radiographic findings in the picture of clinical pain. In younger patients, sometimes we'll find this in people who present with recurrent groin strains because changes of FAI may develop at a very young age, particularly in some sports, such as soccer. FAI may lead to other pathologies such as labrum tear, articular cartilage damage, or advancement of osteoarthritis. It is believed to be present in 10 to 15% of the general population, but we really don't know because many of these people are asymptomatic and we don't have clear evidence of the numbers. Looking at a study that was performed out of Canada and published in JBJS, my slides are a little bit delayed right now. It took 200 asymptomatic volunteers aged 29.4 on average. 80% were Caucasian and over half were female. And bilateral MRIs were performed and were compared to the clinical examination findings of internal rotation, range of motion, and a positive FADIR, flexion adduction internal rotation sign. In this particular study, an alpha angle of greater than 50.5 degrees was considered to be positive for impingement. 53% of the subjects had an elevated alpha angle, and if you increased the alpha angle cutoff to 55 degrees, still a third of the patients had an increased alpha angle. Radiographic changes were more prominent in men than in women. So again, a third had an elevated alpha angle even if you use 55 degrees as your cutoff. Internal rotation negatively correlated with elevated alpha angle. So if your alpha angle was increased, your internal rotation range of motion was generally decreased. There is no significant difference based on age or ethnicity. BMI also showed no significant difference. A family history of total hip arthroplasty was also looked at, and this showed no significant difference as well. Interestingly, only 3 of the patients had a positive FADIR test. So again, a high alpha angle is not unusual and certainly more common in men than in women. Looking at a study that came out of the Netherlands and was published in the European Radiology Journal in 2013, the researchers looked for radiographic signs associated with FAI in a population of hospital patients that were in the hospital for some type of pelvic pain. The age range of the patients was 20 to 60 years, and over 1,500 patients were evaluated. Over 900 of these were females. Patients were included in the study if they fit the age criteria, and at least one hip joint was completely visualized on the radiograph. Now again, these patients were not necessarily in the hospital for hip problems. Exclusion criteria included clinical suspicion of FAI, technically inadequate radiographs, total hip arthroplasty, and other structural abnormalities such as arthritis, dysplasia, fractures, tumor, or infection. From this group, 310 were randomly selected for study. For each gender, the population was divided into 4 age groups: 20 to 29, 30 to 39, 40 to 49, and 50 to 59. A random selection was made by rolling dice for a random starting point. By taking a proportional sample of every age group, a representative stratified systematic sample with a random start was taken. What they found was that cam impingement signs were more common in males than in females, and pincer impingement findings were more common in females than males. Here are findings from a systematic review performed by a Portuguese group published in the European Journal of Radiology in 2016, comparing the imaging prevalence of FAI in symptomatic people, asymptomatic people, and athletes. In the athlete group, nearly 1,400 hips were evaluated, and cam impingement was found in 66%, pincer impingement in just over 50%, and mixed impingement was found in 57.1%. When you compare this to the asymptomatic and symptomatic adult populations, the presence of cam impingement signs radiographically was significantly greater in the athletes than in the asymptomatic population, but not significantly greater than those in the symptomatic population. The same holds for the mixed type of impingement. So an athlete who presents with insidious onset of hip discomfort worsened by activity, worsened with hip flexion, potentially worsened with some ADLs, including stairs and sitting, may have femoroacetabular impingement. Mechanical symptoms may be present. Gluteal trochanteric pain may be the reason for the presentation, and they may have gait changes as well. On physical examination, a limp may be present. They're usually non-tender to palpation. Range of motion is typically limited in flexion, especially with internal rotation, and the hip will often externally rotate with passive flexion. When you test internal rotation alone, you may also find limitations, and a Fader test, flexion, adduction, internal rotation test, may be positive for pain. Strength is usually normal, and neurovascular status is intact. After an appropriate history and physical examination is performed, then X-ray should be obtained, and a 2-view X-ray at the very least, including an AP, and I like an AP pelvis to look at both hips simultaneously, and a frog leg lateral can be obtained. You're looking for aspherical appearance of the femoral head and neck region and measuring an alpha angle if you have the ability to do so. Increased acetabular overhang, a crossover sign, may also be noted. MRI scan can be used to assess for labrum tear or articular cartilage defects. It can also be used to measure the alpha angle quite nicely. Here is an example of the measurement of an alpha angle. Basically, you superimpose a circle over the femoral head. From the center of that circle, you draw a line that runs down the center of the femoral neck, and a second line that makes contact with the circle where the femoral head leaves the confines of the circle, and that angle between those two lines is your alpha angle. Here's an example of what a crossover sign looks like, and you're looking at the posterior wall of the acetabulum marked out in blue. The anterior wall is marked out in red, and the superior aspect of the anterior acetabulum crosses over the posterior wall on the lateral side, and this constitutes a positive crossover sign. Now, sometimes when you get your examination on X-ray, you will see more degenerative type changes, as you do here. You see loss of concavity at the superior head-neck region, or increased convexity is another way that you can state that. The femoral heads are aspherical. You see degenerative changes. The femoral necks appear thickened and shortened. This is classically referred to as a pistol grip deformity. The reason that it developed this name was due to the shape of a musket pistol. The musket pistol, as you see right there. If you look at the handle of the musket pistol, it has a very similar appearance to what you see in the X-ray, and that's how it got its name. So, if it's an incidental finding, and you only have X-ray findings, but the patient has no pain, no range of motion issues, and has good function, you just observe them. If they have minimal symptoms, but no mechanical issues, then observation is certainly something that can be undertaken. But I also would put them on a functional maintenance program of motion strength and proprioception. If they have greater than or equal to moderate symptoms with mechanical issues, then typically I will have them visit one of my surgeons to discuss potential operative treatment. Finally, we're going to talk about hip arthritis. Osteoarthritis is a degenerative process. The incidence of hip OA is about 88 per 100,000 people per year. It's less common than knee arthritis, but it's something that we will certainly see a great deal of as the population continues to age. Increased water content in the articular cartilage with decreased proteoglycans and collagen orientation disorder will lead to articular cartilage changes. The synovium and the capsule also changes. Risk factors for arthritis of the hip include joint trauma, weakness of the muscles that surround the hip joint, high impact load joint activities from work or from play. It's more common in females than in males, and the older we get, the more likely we are to have it. There is a genetic component and also potential developmental component. If you had hip dysplasia, skiffy, or leg calf perthes, you're more likely to develop hip osteoarthritis, but those are secondary forms of arthritis. Presentation is usually that of insidious pain that develops over months or years. Pain will limit function over time. Often patients will complain of pain at night, joint stiffness, and mechanical symptoms. Now, if they have symmetrical joint stiffness that takes 30 minutes to an hour to work out in the morning, you do have to think of the possibility of rheumatoid arthritis, but this is generalized joint stiffness throughout the day. In rheumatoid arthritis, where their symptoms may improve as they get moving about, in osteoarthritis, often the pain worsens as you continue to do more and more activities. On physical examination, you need to assess body habitus because obesity certainly can lead to more problems for these people. You want to palpate the area, but it's typically non-tender. A limp may be noted. Range of motion is often decreased in multiple planes. They may or may not have weakness, and the neurovascular status is generally intact. Be alert in this age group for spine issues, which may also cause hip pain, but to discuss spine pain here is beyond the scope of this lecture. X-rays are the only test necessary to make a diagnosis of hip arthritis. The views that I like to obtain are the standing AP view and a frog leg lateral view. There are many, many other specialty views of the hip that we won't get into. The slide is having a problem advancing right now, so hopefully that'll click in just a moment. The findings that we typically will encounter include joint space narrowing, osteophyte formation, subchondral sclerosis, and subchondral cystic formation. Classifying or grading hip osteoarthritis can be performed using the TONUS classification system, where grade 0 changes are no sclerosis or cysts and no joint space narrowing, basically a normal hip. Grade 1, the femoral head and acetabulum show sclerosis and there is slight joint space narrowing. There may be some marginal lipping also noted. As we progress into grade 2 change, there are small cysts that are noted, along with moderate joint space narrowing and moderate loss of the head sphericity. And then grade 3 changes are severe joint space narrowing, severe head deformity, and large head and acetabulum cyst formation. When you talk about treatment, you have to consider what the goals of treatment are. And this is to control pain, to preserve hip function. Conservative management is key. Weight control, maintenance of range of motion and strength either through home program or formal physical therapy, water-based exercise programs so you can unload the joint during exercise, medications, injections can be of benefit and activity modifications. The surgical treatment and the end game, if you will, is total hip arthroplasty. I always describe the path of arthritis, osteoarthritis of the knee and hip to my patients as a person on a train going towards the end of the line. And the end of the line of life is death. The end of the line of this type of degenerative arthritis is surgical treatment, joint replacement. And as people go down the train track of life, they'll either get to the end of their life or to the end of the life of the joint first. Something's going to happen first. So either they're going to get their joint replaced before they die, or they're going to die before they get their joint replaced. Our goal is to try to improve their pain control, improve their functional status, and try to make it so they don't ever have to get the joint replacement if they don't need it. In 2017, the American Academy of Orthopedic Surgery published treatment guidelines on current evidence and divided the recommendations into 4 stages: strong evidence, moderate evidence, low evidence, or no evidence. And this could be both for and against. Most of the discussion of this paper revolved around total hip arthroplasty, but looking at the conservative management of hip osteoarthritis, here were their recommendations. There was strong evidence for the use of non-narcotic pain management, for example, nonsteroidal anti-inflammatory medications. There's also strong evidence for intra-articular corticosteroid injections and physical therapy. They reported strong evidence against intra-articular hyaluronic acid injection. They reported moderate evidence for obesity being a risk factor for worse outcomes. Therefore, weight loss was recommended. They also noted moderate evidence that mental health disorders were associated with decreased function, pain relief, quality of life outcomes after joint replacement. Therefore, treatment of mental health disorders was recommended. They also noted that if surgery is performed, there is moderate evidence for the use of postoperative physical therapy. Interestingly, there is moderate evidence against glucosamine sulfate. This is also true in their report looking at knee osteoarthritis. The slide again is having some difficulty moving forward. If we move into the low category recommendations, there is low evidence for preoperative physical therapy leading to improved early function, low evidence for tobacco use increasing the complications, and low evidence for increased risk of need for revision in younger patients. So in general, weight loss, non-impactful exercise in a water-based program, physical therapy, and pain control with nonsteroidal anti-inflammatory medications would be the conservative management treatments of choice. Intra-articular joint injections may be of benefit with corticosteroid, but not with hyaluronic acid. And when conservative measures fail, that's when we send folks off to the orthopedic surgeon to consider joint replacement. So that brings us to the end of part 1 of our series of lectures on hip problems in adults. I thank you for your time and attention, and I hope you enjoyed this and learned something. Have a great day.